Hello, everybody. I'm not too sure what part of the world you're in or what time zone you're in. I'm in sunny Southern California, and I want to welcome you to this invigorating, thought-provoking webinar. During the time that we're together, I want to let you know there's a couple little ground rules, and I'm just going to check my handy-dandy cheat sheet here to make sure I get them. I want you to know that as far as questions, I really do welcome questions. I'm going to invite you to, with your permission, to hold them until the end, because then I'll have an ample time to respond. Also, you know, and whenever anyone teaches, it's really, really important for you to give your feedback to see how this was working for you, what other questions you have, if there's anything else you like. So at the end of the webinar, there are going to be a place for you to give feedback, as well as if there are any technological difficulties. So I also will be having my slides will be available to you in two different places. They'll be available through C4 as well as on my own website. So welcome. My name, if you haven't just figured it out, is Louise Stanger, and people either call me Dr. Louise, sometimes they call me Dr. Weezy, or if you don't have a term of endearment, I'm going to invite you to keep it to yourself. So a little bit about me. I've been a clinician since 1973. I'm also an interventionist, and I'm an author, speaker, and trainer. I have a new book about to come out, which I'm excited about. It's a textbook, and it was commissioned by Rutledge Taylor Francis. It's called The Definitive Guide to Addiction Intervention. It'll be out, I believe, the end of September, beginning of October. As far as me personally, I'm a widow. I was a widow. I'm a wife currently. I'm a mother. I'm a grandmother. I've always worked from the time I was 16. And you know what? I'm also a soul cycle adventurer and a traveler. So again, I'm so excited to be with you today, and let's get started. First of all, before I really start about Dr. Suicide, the elephant in the middle of the examining room, it would be remiss of me not to give a big kudos and thank you to Dr. Lauren Walton, who is a fellow Pittsburgh person, but more than that, she's a physician. She's an ASAM physician and an APAP physician. And when I was able to meet with her as she was president of the Los Angeles American Society of Suicide and Prevention, she spoke to me about the dilemmas and pain with such joy and such compassion that doctors face, that she inspired me to actually write the Huffington Post, of which this webinar is based on, and the work that she does in suicide prevention and the work she does with her own medical community. So I just want to, I really admire her. She is a game changer, and she does inspire me daily with her goodness. So what do I hope to achieve with you today? I really hope to whet your appetites. I want to talk to you a little bit about depression, stress, and anxiety, and how it manifests itself in the medical community. I'm going to give you some statistics as it relates to physicians and suicide, including what we call the July effect. And we are right now in the midst, and it's also the August effect. I'd like to explain to you the correlation between depression and addiction as it manifests itself in this population, and demonstrate the efficacy of a robust biopsychosocial with questions. And then lastly, I want to be able to recommend strategies within medical practices and hospitals, which will be designed to reduce risk of doctor burnout and allow physicians the same opportunity that we have to receive the help that they might need. So why do you visit your doctor? I mean, and we know that doctors really sometimes are really glowing with all knowing, because it's all about you when you go to your doctor. It's about you, it's about your loved one that you're worried about, it's about your child. You're going because you need a checkup, or someone else needs a checkup. Something is bothering you. We don't go necessarily that often for well checkups. And you expect you're in an exam that your vitals are checked, there's samples of blood, that their tests are wrong. If you're my age, you might get an electrocardiogram. But do you ever stop to think about what is going on with your doctor? What are he and she actually doing? I wanted to talk to you a little bit about a national best-selling book. And it was written by Dr. Abraham Varghese. And those of you who don't know Abraham Varghese, he is a Stanford doc. This is an excellent book which talks about, with compassion and love, about how hard it is sometimes to be a physician. The protagonist of this novel is a young man named David. And if you meet David, you instantly fall in love with him. He is an award-winning tennis player. He is a great researcher. When you meet him, he is so easy sort of on the eyes. You want to know more about him. And yet, David is much more than just that. David grew up in a home which was beset with mental health or substance. He was often told that he was no good. And for whatever reason, David experiences substance abuse, depression, anxiety, and also acts out sexually. But he's much more than that because he is your doc. And when you see David as his doctor, all you know about David is how wonderful, how caring, how his eyes dance in light, how good he is in quick diagnosis as an ER doc, and that you want more of him. It's important, really, really important to know that more than 920,000 Americans lose their doctors to suicide each year. Just stop and think about that. That's approximately 400 doctors each year become myopic in their thinking, and at that moment in time, they can make no other choice than to kill themselves. Physicians are more than twice as likely to commit suicide than non-physicians. Startling. And female physicians are more than 3 times more likely than their male counterpart to complete. I just want you to sit with those statistics for a while and feel them. Because what can we do for that? Did you know that when we talk about females, their completion rate, meaning actually committing suicide and dying, exceeds the general population by 4 times the normal rate? And after accidents, suicide is the most common form of death amongst medical students, which really we are going to take a look later and really speak to what does our medical schools do to help promote well-being for their students. Common psychiatric diagnoses within the medical community, within the physician community, are depression, anxiety. And can you imagine being a young medical student or a young resident, the anxiety you have that you suddenly are entrusted with a patient, suddenly you have to have a right diagnosis, you have to do it. They're beset with bipolar disease, which means you're manic depressive. One minute you could be high up, another minute you're low down, and some other untreated mental health issues. There's substance misuse and abuse. And there's also, by virtue of being a physician, there's easy access to lethal means because of where you work, what's stored, et cetera, et cetera. And I think what's really startling, if we think about it, the United States loses the equivalent of 1 small medical school to suicide each year, or 1 large medical school class. Again, I want you to stay and sit with these statistics for a minute. And I believe that in every population, when we think about suicide as a result of untreated or depression, I know in the last month, not only did we experience in popular in the popular world, the death of two, not physicians, but the death of two notable figures. One, a famous cook, Varghese, another, a fashion designer, Kate Spade. But at the same time, within that same week, there were 5 other suicides, of which I was made aware of, one including a physician. And what we see is depression, sadness, and sadness might be, as a result of something biopsychosocial, result of family history, or it can be a result of, gee, I didn't do this right. But depression is as common amongst physicians in the general population, and more common depression is in residents. God, did I do this right? Did I mess up a test? Did I do something? I don't know how many of you are experts in your craft, but how did you ever learn your craft? First of all, you had to mentor somewhere, you had to be an intern somewhere, you had to learn. And while you learn, you do make mistakes. That's the way we learn and grow. And depression in and of itself is a global phenomenon when it comes to physicians and also to the general population. But there's been incredible studies done in Finland, Norway, Australia, Singapore, China, Taiwan, Sri Lanka, and Australia. There's been a lot of literature and public saying we need to be able to treat our junior doctors better, and this is across the globe. In a 2016 investigation in Australia, for example, revealed that at least 20 doctors in Australia had lost their lives due to self-harm between 2007 and 2016. It brings up the point, what do we do with our young physicians? How are they treated? How is the curriculum created? Do we give them rest breaks? What are their responsibilities? And do we take a thermometer and say, how do we create a less stressful environment for them? So when we think about things, we think about burnout. And at the Mayo Clinic, which is here in the United States, they used what they call the Mayo-Lush Burnout Inventory, in which they took a look at what particular physician groups really had the highest rate of burnout. And I don't think it's any surprise when we stop to think about it that emergency medicine, an emergency room doctor must act quick and swiftly. I had the pleasure a long time ago of working as a hospital social worker in emergency rooms. You have a person coming in, they are in a crisis situation. You have to decide immediately how to triage and what to do. So you are constantly, you're at the top of your game and you're hyper vigilant and you have to make a quick diagnosis. I often wonder if the reason I became a clinician interventionist is because I worked in arenas where you had to work suddenly, swiftly, with flexibility, and move someone to change. And that's really what happens. The same thing is in family medicine when you stop to think about it. You go to see your doctor on a regular basis. He is your general physician. And once again, you may be telling him, look, I'm fighting with my husband, I'm fighting with my wife, I'm fighting with my partner, everybody's leaving, I lost my job, or I got something good, because stress doesn't know the difference between high success and low success. So it can be in many different ways. And then we see that as we move down there in terms of who's most susceptible, general pediatrics, because there's nothing worse, I think, for a physician, for example, to lose a child, just like it is for you. And also the kind of things are urology, orthopedic surgery, physical medicine and rehab, pathology, radiation, and general surgery subspecialties tend to come in terms of it. But what happens is physicians have, just like you and I, they have other responsibilities. But they have a high intensity pace if we're thinking about the ER room, if we're thinking about they could be in a clinic environment. They have all this, but they're under a time crunch because This is not to discuss insurance today, but insurance demands that people be seen so quickly. So it's not even helping. Not only does it not help you, but it doesn't help the physician who also needs help. And then that physician also may have a partner, they may have family responsibilities. So that's it. And here is just a wonderful chart that if when you get the thing that you want to take a look at, it just lists for you the high stressors in percentage forms. And so there you can sort of see it for yourself. But what happens? Why is there physician suicide? What is the confluence of issues that comes to play, especially with the young physician or the young resident or the person going up to get their board, or maybe even the older one? But there is an extreme educational demand. Think about, if you can, the demands that an intern or resident has. And think about that also, what is the demands that the chief resident or the chief of staff has? They also have very long extended work days. There's no such thing as an 8-hour workday. There could be 10, 12, and 15 hours where they're in the hospital working, and the only place they sleep is in a physician's room. So that is also another way of doing it. There also is increasing computerization. So not only am I going to do that, but I need to make sure that I'm filling in things right, that orders are taken correctly, that labs are run. And I'm operating under a veil of chronic stress because the institutions that I'm about don't support breaks. They don't support the fact that we need some time out. And the other thing is, when you think of young doctors, 90% of them have financed their education. So they are busy also paying back loans in a world where income is not really high enough. And the way also insurance has really worked these days, they're not getting reimbursement. And sort of like you feel like you're a cog in a wheel. You may be doing a rotation. You might have too many difficult patients and you might not know what to do. I can remember when I first started out as a young social worker, my first experiences were in the Department of Orthopedics, which one thinks you break a leg, you feel better, you get knee replacement, you're better. But when I was there, and I was there at a teaching hospital, it was then called University Hospital, but it was UCSD, University of California, San Diego. In less than a month, we had six patients who had Guillain-Barré. Well, Guillain-Barré is a disease of ascending paralysis. Nobody knows why it happens. And all of a sudden, you're trying to help someone who is walking, riding a motorcycle the other day, and then all of a sudden they can't move. And their families are in upset. You don't know exactly what to do because at that time, that was a long time ago, there was no grand protocol for that other than, just treating symptomatically. So you can see how frustrating and how you feel impotent, or if you're depressed, that this is really challenging to do. And there's many more areas of the hospital that you can take a look at that with. Also, there is easy availability of addictive substances. I don't need to speak to any of you today because I believe you're probably all in the behavioral health field. You know that we could walk out on every single corner and get anything we want. But also in a hospital setting, there are ready available of sedatives, of opioids, of medications. And we have sometimes what we call a conspiracy of silence. Let's say we don't want anyone to rock the boat. That's just the way Dr. Sal, Dr. Roger is. He's really a genius. She's really a genius. And you know what? If it's someone who's a chief of staff or head of a department, those under are really afraid to act, and those who are under, we're trying to protect it. So there is a conspiracy of silence. Let's not talk about this. And you can see how close that is to what happens in the arena of substance abuse, because we know in that arena, people tell secrets. And in this arena, they do the same thing. They tell secrets because we don't want it. So we have what I believe is a spider web of silence and an underreporting of when a physician is in trouble, because we don't want anyone to know. We don't want to jeopardize that. At the same time, physicians are people who work in a perfect world. They need to be perfectionists. They may also, though, have family issues, and there might be stigma attached to, I'm not going to be able to tell anybody about this. I'm going to get in trouble. So when we think of it, I love this sort of diagram, is we can see that with someone who is in the midst of really depression, really thinking like, I can't see anything else, their cognitive processes and their brain processes are impaired. And it can be impaired not just from psychiatric, it can be also impaired when you combine it with substance. But, there are life events, there's a functional impairment, there's social isolation, and there's really no way out of it. And so that is how, in some ways, when we think about it, there's all this social disconnectedness. And in that moment that someone takes their life, they don't see any other option. And it's how then do we learn to do that before then? Because at that moment in time, there is no other choice. So when we see it, we see that if we think about it, we see there's suicidal desire. There is a low level of belonging. So I don't have a peer group that I feel comfortable enough that I can actually talk to. I don't belong, somehow that I'm a burden. I will be better off if someone's there. And then we have the desire, well, maybe at this moment I should continue. I'm not going to ever become the doctor I want to be, or I'm never going to be able to do what I wanted to do. And so this is where sort of a confluence of issues comes to bear in someone's mind when someone decides that this is the time for them to take their own life. So what are some of the warning signs that, and I think these probably are ones that you might be familiar with, but that we don't really take a look at when we're doing a quick assessment. Sadness, mood, I don't want to talk. I'm in my room. Don't bother me. Or I'm just not interested. Appearance, I might start dressing really shabby. I might shave my beard. I might just look glassy-eyed. I might be irritable, snap at you. Nurse, give me the right instrument in there. I have anxiety. I might lash out in abject rage. And somehow or other, I might have been at rounds, for example, a young doctor being at rounds, and the chief resident asked you, what was this? What do you think this diagnosis is? And you make the wrong guess. You make the wrong assessment. And all of a sudden, what did you do? Don't you know anything about this, and this? There is that humiliation. And then what about behavior? What about increased use of alcohol and other drugs? It's very readily accessible. And then by the other drugs, I mean opioids, and I also mean marijuana, because we have a losing trifecta going on. And we also know that opioid use, hydrocodone, Valium, leads to perhaps fentanyl or carfenol or other heroin. But I'm not participating. I'm giving away prized possessions. I mean, that is also a warning sign where suddenly, here, take this, I don't want this. Sleeping too little or too much. In a doctor's life, if they're a resident, they're going to sleep too little. Really hard for them to sleep too much. You know, acting recklessly. I'm going to take that motorcycle, or I'm going to use that scooter because it's easier to scoot to work. But instead of like using it responsibly, I'm just like darting in between cars. You know, and some other people might engage in looking for online ways to do it. But then there's this also like visiting or calling people. You know what? You were just the best person. I can't tell you how much I really appreciated you in med school. In terms of our self-talk, when we're contemplating warning signs, and you know what? When you're so busy in a hospital environment or in a medical environment, it's really hard to hear these things, because you feel trapped, you don't have any reason, or you don't want to be a burden to other people, and you're in such pain. But what if your pain is that you were supposed to achieve this and you're really afraid? So silence oftentimes can be a big warning sign as well. In Pamela Wibley, who's a young doctor, wrote Why Doctors Kill Themselves. And what she pointed out, which the New York Times picked up in anything, was medical school culture, hazing, bullying, name-calling, that results in occupational depression and poor health care. So occupational depression is if I'm in an environment that is unhealthy, doesn't support me, actually bullies me, tells me I'm no good, that I can result with occupational depression. And that doesn't necessarily mean that I had a genetic predisposition or that I had a family history of that. There's another way of doing it. The American Foundation for Suicide Prevention found that doctors are drivers of burnout, and there's a workload insufficiency that they have, and that there's a lack of autonomy, because as a young doctor or resident, you always have to get approval from someone else. And that oftentimes we might see with lack of, and the meaning, like, why am I doing this? All I do is get yelled at. All Dr. G does is yell at me. And then what happens to my home life? Let's say I am living with someone, or I'm married, or I have a partner. They don't quite understand the demands of my time, because I am 24/7. I am married to my job, and I don't know of anyone who hasn't had that experience, that has worked in the medical profession and had anyone they love become a resident intern or physician. I'm not saying that's bad. I'm just saying that we really need to be cognizant of the type of environment that we create for our healers, the people that are supposed to save our lives. In the New York Times, another wonderful young doctor, Pranay Sinha, said, there's a strange machismo when it comes to becoming a doctor. Doctors like me feel pressure to project intellectual prowess. I have to know everything, in other words. I must actually appease not only my patients, but the doctors with my veracity. Our expectations skyrocket as the conferral of a degree or an enhancement of infallibility. So somehow or other, once I am proclaimed a doctor, then I become all-knowing. And I guess it was the great Albert Camus who once wrote about that when he wrote about Dr. Knock. Dr. Knock would walk into a room with robes, and actually everybody stopped, listened, as if he was infallible. But in truth, little really changes, according to Pranay, that apart from our legal ability to write a prescription, and to make an assessment in a way in which these might be the things that can help our patients get well. So when we think about this, if we want to try and unpack depression in residents and doctors, it's underreported, underrecognized, and untreated. Doctors, because of the stigma of silence, are reluctant to seek treatment, but they have no time, even if they wanted to seek treatment, because of grueling work weeks. Easy access, as I said earlier, to prescription drugs, fearful of stigma, relational issues, and doctors, if they do not seek treatment, get VIB treatment feeding into narcissistic tendencies. You know what? It's all about me. I can take care of myself. I am very important. I am very entitled. And I don't need any help. That is the other thing that we confer on somebody with a medical degree. They're very important. They know everything. And that's not anything bad. It just is the way we take a look and the sort of pedestal that we put our physicians on. So what do we look for? I think in addition, we really like, and I guess, you know, my area of expertise, not for today, is family mapping. I love to do that, but when we're thinking about talking with someone who has a cloud under them, is there a family history of mental health and or SA? Has there been anyone in their family who has committed suicide? And because that will lead to, for example, generational, perhaps, intergenerational trauma. Has there been a previous episode of depression? Has there been a time when you were a kid when you didn't want to leave your room, when you locked up? Have you ever been treated before? You know, has mom ever been treated? Has dad? What about Aunt Sally or your brother John or your sister Sally? You know, is there any type of process disorder involved? And we all know that when we think about process disorders, we think about disordered eating. Has anyone ever restricted or overate? We think about gambling, you know, because are we doing any high risk kinds of behavior? We think there's all kinds of process disorders when we start to deal with money, spending too much, too little, shopping. We want to take a look, as you know, in terms of Abraham Varghese, when he talked about David. David also experienced a process disorder. He was always trying to be attached to someone, and he had multiple partners, sexual acting out at one time. Or is there you know, in today's day and age, we also take a look at digital. To what extent, and I'm just going to pick up my phone right now. I don't know how many of you were sitting here wondering what you were doing and how much you were like watching messages come in, or do you have nomophobia, which is that can't put your cell phone down. What about work? Certainly doctors and maybe concerned as other high-profile professionals of, you know, workaholism. So, and is there a family history of any addiction or substance misuse disorder, whether it be alcohol or other drugs? Because again, whether it's nature versus nurture, we do know that there is a genetic predisposition or environmental predisposition for families to have some repetitive problems. The other thing you're going to look at in a biopsychosocial, did the family experience any sudden death, any unexplained? Was there abuse? Were there multiple moves? Are they a Holocaust survivor? Is there extreme religious religiosity? And does the doctor have a history of substance misuse? What does that look like? So those are the kinds of questions for those of you who are professionals, if you have the opportunity to work with the doctor or the doctor's family or is concerned, or the team that happens to be his business team, that you're going to take a look at and really want to make sure you know what's going on. And, you know, the other kinds of behavioral health assessments you're going to want to know is what has been the past experience with prescription and non-prescription drugs. Having worked in the medical and dental field, I can tell you that in the past, things were very, very easy to get, and they were sort of not kept in locked cabinets, and there weren't triplicates. And so, you know, what do you take? And we have some good research today, which I've stated in our other kind of presentation that, and it comes out of the University of Arkansas, if you're interested in it, that took a look at if you're given, for example, a prescription of opioids and you've had it for 10 days or more, there's a 20% chance that you could become addicted. You also want to know, has anybody been treated for any disease per the ACM 2011 criteria for addiction? And all of you, if you don't know how the American Society of Addiction Medicine characterizes substance misuse disorder, I invite you just to Google them and go to 2011, March 11th, and you will find that. Has there been any treatment for anxiety or insomnia? Did you take uppers to stay up to pass exams? Did you take downers to go to sleep? Have you had any learning difficulties? We're learning that with learning difficulties, there is a correlation between that and substance misuse. How's your current relationships going? Oh, I just had a breakup. Or, you know what, I can't have a relationship because I'm so many. And what are views on getting and seeking help? Oftentimes, we grow up with families that aren't interested in seeking help. And what are our cultural and religious views on mental health, substance abuse, and suicide, etc.? All those are really important if you are going to be doing any work with physicians. These are the things that you've got to take a look at, and you've also got to acknowledge their work environment. When we think about predictors of depression, this comes from Brighton Kahn at the Mayo Clinic. We see that lack of sleep, making mistakes, again, loneliness, 24-hour responsibility, self-criticism, mood changes, accidents, weight loss or weight gain, and relational difficulties. I just don't get along with the rest of the staff. These are all important predictors. On what happens when we talk about the July effect, what we're talking about is most residents and interns start in July and August. That's when they go to teaching hospitals. So it's jocular, but they all say don't get any operations, don't get any accidents in July or August of any year. There's 19,000 first-year residents in the unit in the United States this year. They put in 80-hour work weeks. Confidence and clinical time are reported in terms of research of their major concerns, and 70% of all interns meet the diagnostic criteria for burnout, the result of severe stress. And unfortunately, with national statistics, there are 250,000 deaths per year due to medical error. So it behooves us to rethink on a macro level, how are we actually treating people? What are our hospital systems doing? And really the big question is insurance helping or not helping create a quality system of care? So here is a cartoon, but it's very true. And this is the way sometimes residents think. And, third-year medical student, that's the brand new person. Now I'm starting clinical rotations. I gotta pretend I know what to do. Those of you that were interns, social workers, psychologists, you all know that feeling. Now all of a sudden you're in a placement and now I'm done with medical school for sure. I just graduated, for sure. I gotta know what I'm doing. Well, no, I'm a resident. I've now gone from intern and I'm on my third year of residency. You know what, I still have to pretend I know what I'm doing because now I've got all these other two people down below looking at me. And I'm above the resident now. I have to also pretend I know what I'm doing, but I get to walk around with coffee and I now am much more self-controlled and attending sometimes, and no disrespect because I publish as well and I be attending in my field. I got to get back to my office. I got to publish papers and books. It's a good thing I've got a great team of underlings. They'll all know what they're doing. And so, we're carrying around this sort of July effect where there's new people coming in. Just think about it in the same way and give the same kind of compassion as if you were going off, you're sending your loved one off to a new school and they're at the bottom of the rung and you've been at the bottom of the rung. So sorry about that. I went the wrong way. I don't know. I apologize. Oh my goodness, this is not wanting to do this. So, you know what I love about the computer is always a little hiccup. So I apologize right now. So what we're also saying is that we need to begin to talk about this. We need to break the silence and we need to break the stigma, and bless those Dr. Signe and Patricia Wiggle, who actually brought to the attention, as along with Kishore and Sean in 2017, we need to begin to normalize about mental illness as a common condition that's in our society, and that also besets many medical facilities. So we have to, because if we do not begin to break the silence, begin talking about, and then put in systems in place, we're not going to solve this issue. So I wanted to share with you just a couple of actual posters, which you're more than welcome to use in your own offices because they're bright, friendly, to give us like sort of physical cues that we need to allow people to be a voice, not an echo, to be the funky colored crayon, which really means in terms of mental health, let's like allow us to express ourselves. These people are tremendous, doctors are tremendously bright human beings, just like you and I. But we need to allow them a place to have a voice, a group, and some sleep as well, so that they can be all that they're meant to be. I believe that one of the most important things in hospitals and in private practice is that there needs to be a really very good development of HR policies on substance misuse, depression, anxiety, and action, and not just policies in which a person who experiences these things is given warnings, but rather policies in which it helps support well-being. There needs to be a review of work hours. How many hours is really reasonable? Let me ask you a question. What's your peak time of working? For me, I'm an early morning person. By the time noon runs around, if I'm writing a book, I've been up at 5, I write, I get up, I teach, but I'm not the best person that you should schedule for a training that starts at 3 o'clock in the afternoon. My burnout, I'm not going to be that 150%. So how many hours do I work? How do I balance my life? What about education and resources about impairments to the medical community? Let's have this an open forum. This is not a stigma. And that there be in place self-referral processes for help that aren't self-referral processes for just write-ups, and that there are confidential referral processes available. And let me be clear, there are many physicians and many organizations that do this across the country. So, but I think that we need to have it on a grander scale, and that people, you all need to, I need to be aware of that my doctor is also a human. When we think about the goal of workplace wellness, we want to make sure that healthy behaviors are promoted, encouraged, and supported, that employees have easy access to help make them a better lifestyle choice. You know, maybe there is not only just a physician's room for sleeping, but maybe there's time where the physicians have time out, or a gym. Wouldn't that be amazing to have gyms inside of hospitals, not physical therapy rooms, actual gyms, that employees have the opportunity to practice healthy lifestyle behaviors, because they're dealing with life and death. And there has to be in place from the top, because it's a hospital or a medical office is a top-down phenomenon. You need the physician, even with a physician's assistant, to make the to do a lot of the heavy lifting. You need nurses, you need auxiliary, and I don't mean I want to encompass all the people that work in a hospital, but there has to be programs, that leadership policies that are supportive and are conducive to healthy behavioral changes. You know, and you've got to stop comparing yourself to everybody. Dr. G and Dr. X are not always perfect. They're human, and the part of it is like, how do we create a milieu in which humanness is acceptable, and one in which we can be visible and vocal, and sort of thank that doctor outside of the box. Thank him for taking care of himself, not just thank him for taking care of you. These again are some wonderful posters I found, which I thought would brighten any single office. When I was doing my research, I was really impressed with the Center for Professional Recovery. There's probably centers like this all over the country, and I'm not related to any treatment center in the country, but from New Vistas Behavioral Health, I felt that they had probably articulated one of the best about well-being committees. And what they said was that a well-being committee, and you can have a well-being committee in a small medical office. It doesn't have to be a hospital setting, but that every type of physician office or medical office should develop well-being committees. And that's a place where you can have evaluations of complaints or allegations to determine validity. You can monitor professionals to protect safety of patients until rehabilitation is completed. There can be proper reporting to appropriate leadership. So no one has to feel afraid. Oftentimes people who are not physicians, nurses, techs, even the cleaning staff, they're going to know when someone is having a difficulty. They're really the ones who may know sooner rather than later. And when they know, they may be afraid because they're higher up, that they won't be able to do anything because no one's going to listen. So there has to be a way, a feedback loop, that people who are concerned about other people have the opportunity to share that. And initiating proper protocols if an impaired physician fails to prescribe a rehabilitation program. There are, I believe nationally, with the headquarters in Massachusetts, a physician's assistance group, which really has its tentacles in every single state in the country, and right now is trying to coordinate physician programs for physicians who experience mental health or depression or substance abuse. And I think that's really wonderful because we need to have that. There's good also research that indicates that if we're able to intervene successfully with depression and or substance abuse, and there's 5 years of monitoring, we have a difference in the life of a medical professional, and that medical professional translates to someone who can help you and I, which is really important. And those lead you pretty much to diversion programs or partial hospitalization programs. And there you would be doing, if you knew someone that was having a problem, you would refer them. But you want to prefer, oftentimes physicians prefer being with their like professionals. So across the country, I do have no fiduciary relationship with any treatment center in the country. But there are some places across the country who just specialize in physicians or executives, and they do a great job with it. And what happened, I know with when I met Dr. Walton had referred someone for me to do an intervention, and she was telling me, for her job, she does meet with all the physicians when they get into trouble, and she's in a hospital system, but the intervention is pretty easy, the invitation to change. The doctor comes into the office, it's actually documented and reported that they have some mental health, substance abuse, or other issues, and they have an option. They can either go to treatment or they can not be a doctor. I love that. I wish I was able to do that with the entire population, because 98% of them always opt to still want to be that person they want to be. At that time, there's also a comprehensive assessment. There's a referral to an appropriate treatment center, and I want to really harmonious. Not all treatment centers are alike. Not all treatment centers are the right one for the right person. And being able to work with a professional that really knows good treatment, really knows what is the right place for that particular person, and also that person's family, that they could. And that aftercare is equally important as inpatient if that's needed, or first medical detoxification, then inpatient. It's really important because aftercare includes ongoing counseling, drug testing, peer support, and ritual. NIDA, National Institute of Drug Abuse, has 7 different things which they really talk about to help someone become the person they are in terms of aftercare. Amongst those is peer support, which obviously you can get from meeting with other physicians. Another one is good nutrition, which really, if you're a resident or an intern, you really don't eat, you're just eating hospital. That's not a priority. Also sleep, also continual ritual, which means ongoing peer groups that can do it, appropriate medication, which means that if it's found that you experience a mental health issue and that you would do well with an antidepressant, that by all means, taking that is it. But also it means taking care of yourself with exercise, being out to be in the sunlight, not being in an office there. And then if there is family that is important, and by family, I don't mean your naval family. I believe that in terms of physicians and other people, that they have multiple sets of families, and one of them is the one they spend the most time with is the family, whether it is their medical practice or the hospital in which they practice, and that family also needs training on mental health and substance abuse and suicidality. It's really important, and they need to know how to set up healthy boundaries and how to support someone in their own recovery. So when you think about it, I like this little schema I found. When you think about it, I wish I had a little pointer. I'm pointing to you to screen, but you'll see that some people may have drug abuse, alcohol abuse, opioid abuse, smoking. They might also have depression. And how are you going to get there? Well, if it involves substance abuse, you're going to probably need medical detox 98% of the time. You might need to go into inpatient. And most of the time docs don't like being away, but they stand the chance of losing everything. And I've worked with a couple of physicians who were female physicians who had really tried to take their own life with opioids and with other types of anesthesia. And, we're fearing the loss not only of their loved one, but also of their children. And how do I get back in the good graces of a medical board? How am I going to be that woman or that gentleman physician? And then you have to make sure that there's a team that can be there. Wouldn't it be wonderful if even in a large hospital system, there was a counseling office set up where you could go, you could drop in, you could have an anonymity for well-being, that was part and parcel of the way we structure things. When we think about continuing care, because for someone who has mental health, suicidality, has had suicidality thoughts as well as substance abuse, it's really important to think about aftercare. And it also, we know with physicians right now that there's been great success with physicians, pilots, and teachers with a 5-year long-term monitoring program, which includes counseling and what we call random drug testing. But it also means that if nothing changes, I have in one of the books I wrote called Falling Up, I have a chapter called Nothing Changes Till Something Changes. And I really do believe that unless someone's not going to live in a world where their other family and friends are, that family and friends also need to change. They need to take a look at how have they unconsciously, unwittingly aided and abetted this? How have they sort of turned the other cheek, tried to fix it on themselves? And what can they do to begin to take care of themselves and also set healthier boundaries? routine reporting back to medical boards is important. It keeps us accountable, just as I would be reporting back to a board of behavioral science examiners. Reassessments and evaluations, and really celebration. Probably the greatest gift a physician in recovery or a physician who's experienced these things can be a leader, because in their openness, if they choose to share, they can be a leader and a role model for others. And how do we find joy? I mean, finding joy, finding goodness in our world. I remember several years ago, I had the privilege of working with. I was doing an intervention actually on someone's sister, but the family was beset with a history of depression and a history of suicidality. And one of the family members was a lovely psychiatrist who grew up in a foreign country for many years. But he talked about how he was able to make peace, because he too had suicidality in his background. And how did he find joy? And it was simple, and yet it's so difficult. It's being able to take care of yourself physically and emotionally and consistent with your values, and doing that in a way that harms, and also being open and getting the help that he needs. It was very heartwarming to hear him be able to speak his truth and to talk about the work environment he created, so he was able to do that. I want for you all to imagine systems in place which really support you as a patient, because when we go in, we're hurting, we need help. But also I want you to place a world in which we also support our healers, those trusted servants that we engender ourselves and our loved ones to. I think that there is always, always possibility in that endeavor. And I want to stop for a minute right now and see if there are any questions that any of you might have. I don't know, because we had a little technical difficulty, and so I'm going to have to ask Jesse if we did have any questions.
Thank you, Dr. Stanger. Yes, we do have a couple of questions and a few comments, if you're ready for those.
Yes, I'd love it.
All right, the first question is, the conspiracy of silence you describe is very real and also includes many more deeper levels of culture of shame, humiliation, misdirected assignation, and incorporation of guilt for poor outcomes and outright abuse, particularly of women medical students, residents, and fellows. Would you please uncover more about the culture of humiliation and abuse that begins in medical school?
Well, I guess one of the people, I'm just going to invite you to take a look at Balm and Gilead. I use a research methodology called portraiture. It was developed by a Harvard researcher who's African American, and her name is Sarah Lawrence Lightfoot. She's quite a remarkable woman, and she talks about portraiture. Her mother, she writes about in Balm and Gilead, was African American and also of Native Indian descent. She wanted to go to medical school, and yes, she was allowed to go to medical school, but she was also only allowed to attend behind a curtain. She was not allowed to be present in any way, shape, or form in there. And I think that when we think of doctors, we think of males. And as we know, I grew up in the 1960s where actually, women burned their bra. Helen Reddy said we could be women, hear me roar. But if you look at the history of admissions, women were not readily admitted into medical school, and to be seen as peers, not to be seen as traditional, as being able to break the glass ceiling, not being someone who is going to be there for the short term, meaning I'm going to go become a doctor, then I'm going to leave because I'm going to get married, I'm going to have children. So I think that you're absolutely correct in that we have this unconscious way of looking at women as if they're not good enough. And if you look at every profession in the country, women are paid less. And I want to say, whoever wrote that, you are absolutely positively eloquent. with your words. So thank you.
Okay, the next one is, and I apologize if I'm mispronouncing this, what do you think of the Balint Society? Seems they have a good grasp of peer support for medical professionals.
I don't think I can. I think that they do a good job. I don't know enough about them to really comment, but I will research that and be able to give you excellent comment. And if you could articulate a little bit more about what you mean by that. And I don't know if they're nationwide.
Okay, and then we have a few comments. I'm not sure if these are necessarily questions, but I'll go ahead and read those if you like. Thyroid disorders, adrenal insufficiency, destruction of circadian rhythm may be undiagnosed and untreated. Please include these in your presentations.
I think there's all kinds of, thank you. I think that what's really important when you're doing a biopsychosocial is that you have a complete medical physical, and that means not only that, not just thyroid, it means that, you know, how are my adrenal glands working, etc. Not being a physician, I am only, have doctorate. I am hard pressed to, I think that's a great idea, but I think if probably what I would add is a complete physical, and these are some of their arenas in which we need to check, which is not only just thyroid, but also adrenal glands. You know, is everything working the way it can? Because in what way, if these are not working properly, how does that then affect our mood and our balance? So thank you so much for pointing that out.
Okay, the next comment is the 80-hour mandates are widely violated. Some departments describe this as 80 hours of patient contact. Then you need to use your own additional time for reading, CMEs, preparation of cases and rounds, and any research to promote your career.
So I would invite you, for those of you that are bound by 80-hour rules, in terms of being able to actually join together, and being able to present alternate policies, but I think you're going to have to band together as a group, not as an individual who has did that. And so if you happen to be a resident, if you happen to be head of residence, taking those concerns to and documenting them. Unfortunately, you have to document everything, taking those concerns to the appropriate administration, and taking it also to, when we talk about medical schools, there are deans of medical schools, there are student grievance committees. I think that in today's day and age, where one's voice is certainly, this does not have to happen to you. It really doesn't. And so if you join together with voices, I think we can begin to effectuate change. Change, though, on large bureaucracies is always slow, but I think that you need to bound together and make this a public statement. And I appreciate forums like this, which are really inviting people, inviting medical schools, inviting medical practices, and inviting large-scale hospitals, and even inviting insurance companies to look at the ways in which inadvertently they are facilitating non-healthy behaviors, or they're facilitating anxiety and stress, which can lead to depression or substance abuse, or they're facilitating long work hours, because they are responsible in many ways. But I think as individuals and on a micro level, we're responsible to join together and to form groups so we can bring our cases that aren't just ones of anger, but ones in which we have solution. I think a problem articulated without a solution doesn't get you anywhere. But I think that's a great question. Comment.
Okay, we have a comment and a question here. The comment is, I see this as well with fire, police, and EMS personnel. And the question is, do you also advocate the culture of shame and loss of values in DV and trauma suicide in the medical and services community?
Okay, I think that my colleague, Brene Brown, did a beautiful job of talking about shame. I'm not good enough. And today we were just talking about doctors, domestic violence, growing up saying I'm not good enough, being bullied, being humiliated. These are things that one finds in a variety of different segmented populations that we really need to be looking at. How are we really telling someone they're good enough? Are we really telling them that they're okay? You're not smart enough. And so I think that you see domestic violence in this population. You see it in other populations. I mean, basically, when we think about this, we think about pilots, we think about police, we think about police, sheriffs, firefighters. All of these people have high risk kinds of jobs. I did have the opportunity, for example, I like expertise somewhat in sudden death, grief, and loss. And when 9/11 happened, I had the fortune of working with the widows of 9/11 because of the sudden death. And what happened also with some of the firemen, anxiety, depression was at an all-time high as a result of a natural disaster. I don't know if that answers your question or brings up more questions. Physicians are not the only group that experience this phenomenon, nor are they the only group that needs to develop well-being centers within their framework and work hours, which become ways in which we can take care of ourselves emotionally, physically, and consistent with our values. Thank you very much for the really thought-provoking question.
Okay, we have a few more here. This one's a comment. In our Harvard residency, every July, the department chairman would always take an entire month's vacation, disappearing to the other side of the world physically and entirely off the grid, so that nothing that happened within the department during July would ever be attributed to him. Also, all healthcare professionals know never to have surgery during July. It's just too risky.
Well, that's exactly, if you saw that cartoon earlier, I am a social worker, okay? I'm a licensed clinician, and everyone will tell you that every psychiatrist in the world used to be a joke. We'll go out on vacation, and there's actually a book written about the August factor. I think what that does is it invites one, and that's to rethink about how do we give vacations? What is our leadership doing? And do we really take, as a professor, when we had incoming students, we actually spent much more time with student orientation, with getting them ready, with actually being in their first year classrooms, with young master's degree students. This is where you need to be. And so perhaps that is a wonderful point, and it's one in which one needs to write about and also needs to address on a macro level with department heads. Perhaps it's better for you to take a vacation not in August, but there is that July-August phenomenon, and that's why, part of the reason when I developed this presentation was to bring that to the forefront.
Okay. Do you want to take a few more?
Just a few more. I mean, you're just such a brilliant, wonderful audience. Thank you. And let's take about 2 more questions. And if you have any more, I can probably at the end tell you how to get in touch with me, or we can continue this dialogue another time, but I really appreciate it.
Okay, the next says, in medicine, physicians are trained to place their flames of attention on pathology rather than on well-being. This warps us for the duration of our lives. We are oriented toward acute care rather than prevention. Again, a major warping of our perspectives that often last for our entire lives. We forget and have never learned or valued the continuously necessary nurturing roots of well-being.
So I assume that's a comment. I want to thank you that you're saying that the way the education is structured, what you're looking for is pathology or what is wrong with someone. So when I work with people and when I try and reframe things is I work from, and I think, what is working right. I operate from a strength-based perspective. And part of the time I'm inviting people, and especially when you're working with someone who has, you're not going to minimize their dark feelings or their substance abuse, but once they're better, I invite people with their permission to take a look and do things to take care of themselves physically, emotionally, and consistent with their values, or spiritually. And in a joke, I invite people to do 9 things each week in each of those categories, and an easy way to do that. So you have a lot of things filled. And in a more jocular way, I ask people from A to Z. So I'm sure that when you take a look at a patient, my hope is that you would say, hey, if you're looking at me, this is a reasonably robust, healthy, almost 72-year-old woman who has had only one major surgery of knee replacement, and who has a family history. I'm going to just use myself, of suicide in her family of origin. Father and 2 grandparents had a history of substance abuse, and she appears to be pretty resilient and able to do work to help people. What does she do to take care of herself, given that, and so I think you need to take a look at yourself too, and say, with all your patients, because I know you're doing that with your patients, what are their strengths? What can we do to help enhance them? And then for yourself, I guess I'm inviting you to look at, what is my cup full of, and how do I begin to take care of myself? And then bring that culture, because there is a culture of wellness and a culture of prevention. I think insurance companies have done a long way of not enhancing or treating well-being. They don't pay for a well-being check. Thank you, though. Great question. Great comment, rather. Do you want one more?
Okay, and the last one is just an attendee wondering where they can get a copy of your presentation slides.
So I'll tell you how to find me. You can, first of all, I am my own personal assistant. So if you want to call and ever chat, you can pick up the phone. And if I'm not helping a family or anything, you call me at 619-507-1699. If you're interested in any of my blogs or writing, I do a lot of writing for Huffington, for Thrive, for A Sober World, for lots of different places. And we have a textbook coming out in September, called, it's a very pedantic title, The Definitive Guide to Addiction Interventions, a Collective Strategy. Thank you to Rutledge and Taylor Francis. Or if you want to read more about me, you can buy a book on Amazon called Falling Up, A Memoir of Renewal. My website is www.allaboutinterventions.com, or just Google my name. I do have slide shares up on my website. I do them all myself, so I think there's a little hiccup in which I spelled suicide wrong earlier today. And also, Jesse, can you tell them how C4 is going to have this up?
Absolutely. So we are going to have a link back to Dr. Stanger's website on our webinars page. It will link directly to the slides for this particular presentation that are hosted on Dr. Stanger's website.
And, from the bottom of my heart, I just want to thank all of you with your comments and your questions. It is very heartening. I can't see any of your faces, but it's so heartening to know that there are people that are truly interested in this issue, and who together we can really make a difference. We can be visible, we can be vocal, and we can be visionary. So thank you so much.